Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Sanjay Kumar and my old student, Dr. Naveen, for inviting me here in this August gathering. So, I would be talking about newer therapies for hepatocellular carcinoma, and with the permission, I have slightly modified the topic. I will talk more of newer treatment approaches for the hepatocellular carcinoma. So my agenda would cover all these aspects: liquid biopsy for HCC, adjuvant therapies after curative treatment, downstaging and neoadjuvant therapy, new drugs in pipeline, and precision and personalized medicine. So many of these aspects are still not there in guidelines, but active research is being going on. And we may soon, in next 5 to 10 years, see many of these aspects being practiced widely. So coming to the liquid biopsy for HCC. So to understand what is liquid biopsy for any cancer, we need to understand what biomarkers are released into the blood from any tumor. For example, if liver is there, what biomarkers it will release? So it will release proteins, and it will release metabolomic markers. For example, proteins can be alpha fetoprotein, PIVKA2, and certain metabolomic markers like bile acids, carnitine. These are the usual biomarkers. But apart from that, there could be other biomarkers which are released. For example, there could be extracellular vesicles. There could be circulating tumor cells themselves which are released in the blood, or certain nucleic acids which can be released. And these form the basis of liquid biopsy, which is now coming into the oncology practice of any cancer, not just liver cancer. Especially the nucleic acid which is released from these tumors are very important, and these are studied most. And especially the circulating cell-free DNA. So DNA which is not there in the cells but is circulating in the blood cells is studied and is most promising. It is also, once it comes from the tumor, it is also called as circulating tumor DNA. So what is cell-free DNA? So normal blood does contain some amount of cell-free DNA, and most of this in healthy person is derived from various sources of the body. For example, if we do the analysis from where it is normal cell-free DNA is coming in the blood, it would be lot of them would be coming from the blood cells, neutrophils, T cells, B cells, and some of them would be coming from various organs of the body like lungs, liver, heart, and kidney. This would be in normal persons. And physiologically, in normal persons, these cell-free DNA would increase with various physiological conditions, including exercise. Even exercise would increase the normal cell-free DNA of the body due to wear and tear. And also in pregnancy, the cell-free DNA increases, and that can be basis of detection of various abnormalities in the fetus. But pathologically, cell-free DNA increases with various inflammatory diseases. For example, even in rheumatoid arthritis, it can increase, or it can increase due to various cancers. For example, any of the cancer, it can release. And for the cell-free DNA which is released from the tumor or cancer is known as ctDNA, or circulating tumor DNA. So in HCC patients, with advancing tumors, some of the cells are released, as well as cell-free DNA, and various other biomarkers are released in the blood. Of them, when we study their nucleic acid or the DNA, we can study the mutation as well as epigenetic changes. So mutation like TERT mutation, CATNMB mutations, or any epigenetic changes like methylation can be studied in these patients. So there's been recently an EJM paper on cell-free DNA technology to detect colorectal cancer screening, which was there a few weeks ago. And similarly, there have been papers which are coming which are studying cell-free DNA testing for early hepatocellular carcinoma patients. So within next 3 to 5 years, cfDNA-based technology or liquid biopsy will be routinely used for not only diagnosis but also for surveillance, treatment response, recurrent detection. So right now this is a very nascent field, and with in next 3 to 5 years we will see more and more papers, and it will be widely practiced. Coming to other aspect of HCC therapy, what is new in it. So talking about adjuvant therapies after curative resection. So in early stages of cancer, this is the inasal BCLC staging. So when the tumor is in early stage, stage 0, stage A, or early stage, the treatment modality of choice is either ablation or resection, or also transplantation. So after ablation and resection, usually although the tumor is cured at that time, but there's a very high recurrence rate, up to 70% in 5 years. So how do we check that recurrence? So initially, once the sorafenib had come in 2008, they tried adjuvant therapy after resection and ablation of these tumors, but it was not successful. And the giving sorafenib after resection or ablation did not help these patients, and the recurrence-free survival or the overall survival remained same. But with the emergence of immune checkpoint inhibitors and latest immunotherapy, similar studies has been done, and which have been published just a few months ago, where atezobev was given to those patients who underwent resection or ablation, and these patients had a very good recurrence-free survival. And so this study, which was IM-BRAVE 050 study, paved the way for adjuvant therapy for after resection or ablation of early tumors. So what is the concept of immune checkpoint inhibitors as adjuvant therapy? So whenever some tumor is there, even though it is small tumor is there could be certain occult metastasis at distant site in the same liver, which could be there. So once we are doing surgery for these tumor, we are removing these tumors by surgery or doing ablation, the tumor is completely removed, but we are not able to remove these occult metastases. So once we have given immune checkpoint inhibitors, it will recruit all the T cells and cytotoxic T cells, which will not only take care of the site from where the tumor was removed, but also at the distant site, if there are certain metastases, these prime T cells will take care of these cells. So more and more, apart from the 050 study, which I mentioned, more and more studies are now coming, which are showing that giving immune checkpoint inhibitors as well, or combining with tyrosine kinase inhibitors, there are better chances of having reducing the recurrences in these tumors. And many ongoing trials on adjuvant therapies are going on, and whose results are expected within this year or the next years. So who needs adjuvant therapy after resection or ablation? Especially those patients who have got high risk of recurrence. For example, if the tumor size is large, number of tumors is high, they are having microvascular invasion or even segmental portal vein invasion, or poor differentiation on histopathology. So after resection, if you find these features, these patients merit adjuvant therapy. Similarly, after ablation, if the size was large or multiple tumors, these patients would merit. So in next edition of HCC guidelines from various societies, we would definitely see that adjuvant therapy would be strongly recommended. Coming to the downstaging and neoadjuvant therapy. So what are the pre-operative treatment therapies which can be given? So if there is a resectable tumor and we are giving neoadjuvant therapy to prevent recurrence of the tumor, this will be called as neoadjuvant therapy. But if the tumor is very large and it is not operable, and if we are giving some kind of pre-operative therapy to reduce the tumor burden and then convert it to a resectable tumor, then this type of therapy is called as conversion therapy. It's also a form of neoadjuvant therapy, but we call it as conversion therapy. Similarly, if the HCC is within Milan criteria, but we are not getting the donor, he's in the waiting list and there's a lot of time, potential time, so the therapy which we give to these patients would be called as bridging therapy. And if the tumor is outside the conventional criteria, outside Milan criteria, outside UCSF criteria, and we downstage the tumor, then this is called as downstage. So all 4 of these types are neoadjuvant therapy, but with different names. So talking about downstaging, as you all know that Milan criteria is the best criteria which gives a 75% 5-year survival. And as we expand the criteria beyond Milan criteria, as the tumor number or tumor size increase, the 5-year survival decreases simultaneously. So can we actually, if we get a patient who is presenting beyond Milan criteria, but still we want to give him the best survival of 5 years, 75% 5-year survival, the best way would be if we are able to successfully downstage this tumor to within Milan criteria. So which patient should we downstage? So in our 2023 guidelines on HCC, we had mentioned that patient who present with Milan criteria or UCSF criteria, these can be taken up for upfront liver transplantation. But those patients who present beyond UCSF criteria, it would be better if we downstage these patients to meet the UCSF or Milan criteria before taking up for transplantation. So is there any upper limit of stage for downstaging? The usual UNOS criteria is that we should take up for downstaging only those tumors which are less than 8 centimeter, and a certain number of the tumors are there, but no vascular invasion on imaging. But these criteria are restrictive and applicable more for DDLT setting. In India and various countries now, we have seen that even those patients who have already having portal vein tumor thrombosis, this is a study from Dr. Soin's group. Even these patients, after successful downstaging protocol, are having good survival outcome, good overall survival as well as recurrence-free survival. So the pragmatic downstaging protocol would be to, for all comers who are beyond UCSF criteria but having no extrahepatic metastasis, we should offer them multimodality treatment in form of loco-regional therapy, Y90, SBRT, any of these depending on their stage. And also add systemic therapy to this, and then see, assess. Many of these patients would be successfully downstaging with this multimodality treatment, and now they are meeting UCSF criteria with acceptable level of tumor markers. Then also we immediately should not subject them for liver transplantation. We should give them a 3-month mandatory period, waiting period, to assess their tumor biology. If even in that 3 months they remain downstage, we should offer them LDLT. But if with multimodality treatment they are not successfully downstage, that means these patients are having a poor tumor biology, and these patients will continue with multimodality treatment. And also, even in the 3 months mandatory waiting period, if many of these patients do progress, then obviously these are not good candidates for LDLT, and continue with the multimodality treatment. A brief about conversion therapy. Now, many trials are coming on where unresectable HCC, if we combine multimodality treatment in form of TACE, SBRT, immunotherapy, it can become resectable. So recently the StarFit trial was there, where initially they had 68 patients which were unresectable, but with this multimodality treatment, up to half of them became resectable and with very good survival. So all stages of hepatocellular carcinoma can benefit from combination of multimodality treatment, loco-regional therapy, systemic therapy, even early stage tumor, intermediate stage tumor, or advanced stage tumor. There are many newer drugs which are coming. In our 2023 guidelines, we told that first-line therapy would be atezolizumab, lenvatinib, sorafenib, and then 2 more treatment options had come. But in next 2 to 3 years, we are going to have at least 10 more options for first-line systemic therapy, which will soon come. A brief about precision or personalized medicine. This depends on the tumor microenvironment. So tumor or cancer is not just a collection of malignant cells. It has got a lot of microenvironment in which it lives and thrives. And this tumor microenvironment contains a lot of stromal cells, immune cells, which actually feed these tumor cells and protect these tumor cells from immune damage. And this tumor microenvironment leads to three types of tumor: hot tumor, that which has got lots of inflammatory cells; cold tumors, which has got less of inflammatory cells or excluded cells. So in next 3 to 5 years, we'll see more and more biopsies being done, which will determine whether the tumor is a hot tumor or inflamed tumors, which will benefit more from immunotherapy, and cold tumors or non-inflamed tumors where immunotherapy will not be so much effective, and these will benefit from more surgical or loco-regional therapy. So lots of personalized treatment will be coming in next 5 years. So HCC treatment approach is now evolving at a very rapid pace. Liquid biopsy will be the future of early diagnosis and surveillance and treatment monitoring. Adjuvant and neoadjuvant systemic therapy will be given to most patients in future, most patients receiving surgery and loco-regional therapy, and more patients will receive liver transplant after aggressive downstaging protocol, and personalized treatment option depending on tumor microenvironment is also on the horizon. Thank you for your patient hearing.